And thanks to the organizers for letting me take part in this exciting session about age. I'll talk about young patients, young PGT-M patients coming to our clinic to prevent the birth of a very sick child. I have nothing to declare. And I would like to start with highlighting a major policy shift in our clinic in a way we approach PGT-M. So in July 2021, we shifted from standard PGT-M, in which we focused on haplotyping to detect the inherited disorder in the embryos, to comprehensive or co-PGT-M, in which haplotyping was combined with information about the chromosomes of the embryo. So in that way, we were able to enhance embryo selection. So this shift had clinical implications, outcome-wise, and this is where I will talk about today. But it has also had some implications in the way we interpret the result, how we report the result, and how we counsel our patients. So the rationale behind this policy change lies in the growing understanding of the role of chromosomes in reproductive failure. It's said a lot of times today, including early pregnancy loss and a longer time to pregnancy. In particular, in PGT-M patients, these patients invested a lot emotionally and logistically in their pre-treatment workup. So especially for them, a longer time to pregnancy and pregnancy loss may carry an extra burden. So our central hypothesis was that by incorporating aneuploidy screening for these patients, we could enhance reproductive outcomes, namely reducing the pregnancy loss and shorten the time to pregnancy. I think it's essential to acknowledge once more and to repeat here that there is currently no robust evidence that aneuploidy screening, and I'm especially talking about standalone PGT-A, that this consistently improves the key reproductive outcomes. Especially in younger patients, and these are our PGT-M patients, the debate is ongoing. And just as a matter of example, I'll show you here some SART data of a couple of years ago, and they even saw in their register that when you performed PGT-A in patients under 35, they even saw a reduction in the cumulative live birth rate. Age matters. It's said a lot of times already today, and you all know these graphs, and these graphs illustrate very clearly that euploidy rates are strongly age-dependent. But in young women, such as the women in our cohort, the majority of embryos will be euploid. And this raises some question. Are we doing the right thing by combining PGT-A to our PGT-M patients? Because is there an added value when you perform aneuploidy screening in a population in which the baseline risk is very low? Now, however, in the context of PGT-M, I want to express that these embryos are already undergoing a biopsy, a trophectoderm biopsy. So you don't add an added risk procedural, nor for the embryo, nor for the patient. So this is a quite unique context to look again and to re-evaluate the utility of PGT-A in younger patients, not as a standalone test like PGT-A has been investigated many times. So we wanted to assess the result in our clinic after the policy shift, and we did so by looking retrospectively at two cohorts, the old standard PGT-M cohort and the comprehensive PGT-M cohort. It was a single-center study, and we only included rank 1 cycles, so patients that underwent for the first time an IVF cycle. So in this way, we were working with only ART-naive patients. And we included cycles from the moment at least one blastocyst was biopsied. And we looked primarily at the cumulative live birth rate, defined as having at least one live birth from the considered retrieval. We also looked at time to first live birth. This was defined by the number of FETs that were necessary to reach this first live birth. And secondly, we also looked at the clinical outcome per single embryo transfer. And we followed these patients up until May of this year, and these were FETs done until September last year. So looking into our files, we identified in total more than 800 PGT cycles. And then after exclusion, there were 275 left, about 130 retrieval cycles in both groups. And here you see the baseline and cycle characteristics. And first of all, I want you to look at the basic baseline characteristics of these patients. And we dealt with very young patients. The mean age was around 30 with a small confidence interval. They had a normal BMI and a reasonable AMH level. Although in the co-PGTM group, the number of COCs and mature oocytes was significantly higher if you look at the number of zygotes, and more importantly, the number of blastocysts available for biopsy. This was not different between our groups. And once more, I want to put or tell you that we were dealing with very good prognosis patients, 30 years on average and 6 blastocysts. Just for your interest here, I'll show you the mode of inheritance. And as you can see, there was a slightly higher proportion of autosomal recessive disorders in the co-PGTM group. But if we then calculated the theoretical chance of having an unaffected embryo, this was not different between our groups, and this was a little bit more than half of the embryos expected to be unaffected. If we now proceed to the embryo results, these were the results after the first biopsy. And as you can see, not surprisingly, in the co-PGTM group, more embryos were rejected after the first biopsy. And if we then add the results of the rebiopsy and then look to the final result, in the PGTM group, 701 embryos were biopsied and 46.2% was eligible for transfer. In the co-PGTM group, 801 embryos were biopsied and 38.6% were eligible for transfer. And this was significantly lower. This was, in my opinion, not unexpected. What we did see is, if we then looked per cycle, per retrieval, there was no difference anymore in the number of embryos available for transfer. Most probably, this is due to the fact that in the co-PGTM group, less embryos than expected showed to be affected, and this was the opposite in the PGTM group. So if we now zoom into why we rejected embryos, and if we zoom into the co-PGTM group, we see that a number of embryos, a little bit more than half, was rejected because of the presence of the monogenic condition alone. And then another 17% of the rejected ones were rejected because they had the monogenic condition and a chromosomal imbalance. And then the embryos in the red boxes are the most interesting ones because those embryos were unaffected if you look at the monogenic condition, but they had a chromosomal imbalance. So these were the embryos that would have been eligible for transfer in the old standard PGTM strategy. And if we sum up the embryos that showed to be chromosomally abnormal, we end up with 26.7% to the total amount of biopsied embryos. And this is actually what you would expect in a patient cohort with a mean age of 30. So if you then look at the raw outcome, so per single embryo transfer per FET, you can see that there is a tendency towards a higher live birth rate in the co-PGTM group, and the opposite was seen when you looked at pregnancy loss. However, we should interpret these results with a lot of caution, since multiple embryo transfers can happen in the same patient. So these data points are not independent, so that's why we applied a GEE model and this account for intra-patient correlation. So if we performed this GEE analysis for live birth, we included 403 transfers in 213 patients, and we found that the odds of having a live birth was 86% higher in the co-PGTM group, and we adjusted for embryo quality. If we then looked at pregnancy loss, we included 194 ACG positive transfers in 146 patients. We saw that the odds of having a pregnancy loss was estimated to be 50% lower in the co-PGTM group. So if we then look and go back to the cycle, the retrieval, the outcome per cycle. And this is actually what, in my opinion, matters to your patients, because your patients will ask you, "Doc, will I be pregnant after my first cycle?" Here are the answers. If we look at the proportion of patients having at least one eligable embryo for transfer in both groups, it was more than 80%, 85%. If we look at the proportion of patients that had at least one FET, it was also similar and more than 80%. And if we then looked at what proportion became pregnant, had at least one positive ACG, it was more than half of the patients in both groups. What was significantly different was the proportion of patients that didn't have a transfer yet, despite having suitable embryos. However, the absolute number in both groups are quite low. So I'm convinced that even if they would have had transferred yet, probably this wouldn't have changed our outcome results significantly. And what is most interesting, in my opinion, from this cohort study is that there was no significant difference in the proportion of patients with at least one live birth. Neither we saw a significant difference in the number of FET cycles needed to reach this first successful pregnancy. So at least we could say for our center, for our patients, that by shifting from standard PGT-M to co-PGT-M, we were not compromising their overall success rate. This is also shown here. What was interesting is that everyone who reached a live birth did so within 4 transfer cycles. You see indeed, I have to admit that there might be a difference in the first cycle, but once you proceed to a second, third, fourth transfer, you can't see a lot of difference anymore between our cohorts. And this is, again, the result. Cumulatively, you couldn't show a significant difference. And here again, you might see a small tendency, but at least we couldn't, this was not significantly different. So to conclude, in our young PGT-M ERT naive patients, we were not harming them by adding aneuploidy screening. We saw higher odds of having a live birth and lower odds of having a pregnancy loss. And PGT-A is one way in looking to embryos. It's a selection tool, but I believe in these patients, if you have a tool with which you can reduce pregnancy loss, I think it's worth considering. We saw no differences in cumulative outcomes, so we didn't compromise the cumulative outcome, and also the number of transfers needed to reach a live birth didn't differ. However, to end, I want to remark that even in the co-PGT-M group, we saw a first trimester loss rate of 14.9%. So I also think it's important to counsel your patients that excluding aneuploidy does not guarantee a successful pregnancy. And I want to thank all the people from our department, also the people from the medical genetics department. And there are many more that I've not noted there that are caring for our patients day by day, and I also want to thank them.